My name is Dr. Igor Borisov, and I've been practicing dentistry since 2019. And I've been a proud mentor and instructor for Implant Pathway since 2022. And I've been placing implants pretty much since 2019, but the Pathway mentorship and collaborative unit of mentors and instructors really upped my game in the last few years. What sparked my passion is really giving life back to patients. When you place implants, you not only restore their function, their aesthetics, but you restore the person as a whole. Because I like to say if somebody doesn't have teeth and they get teeth back, they're almost living like an amputee for a while. And even though they do get a prosthetic back, you can see this like glow of confidence about them. They start smiling, they start speaking better, eating, and it's very rewarding. The team itself is what sets Pathway apart. Everybody here is treated as an equal, attendees, mentors, long-term instructors. So nobody has an ego around here. And when you come as an attendee, doesn't matter how many courses you take, you're always part of the Pathway family afterwards. Messages each other, the mentors learn from one another. The mentors can sometimes even learn from the attendees. And not to mention, we have a plethora of courses that the attendees can take. The basic implantology skills from just starting the digital planning, prosthetically driven implant planning, to actually performing your onesie, twosie surgeries, and all the way up to full art surgery. And for the very advanced placers, we even have remote anchorage courses here as well. Pathway's mission to train the next generation of dental professionals, I align completely with the goal because the way we teach implants here is to strive for perfection for the patient. And we want to teach implant systems and a way to do implantology that will pretty much guarantee a perfect restoration. Because nobody comes here, no patient wants to go in and get a screw placed. Patients come in and they want a tooth, or they want a row of teeth. They want to smile, they want to eat. So we go through the planning phase, the acquisition, the surgical phase, and the prosthetic phase. And all those phases we apply to the patient. And that's when, if we do plan the implant, we're taking into account all of those factors to give them the perfect product. I hope that my students will do good for their patients. It's almost like a joke, but it's also half serious. When I mentor a course or if I lecture, like I'll be doing in Chicago soon, I want to tell the attendees that, this isn't like to scare you, but I personally feel responsible for pretty much every implant they place after this because I taught them the very basics of implantology. And that's why I want to make sure I do a really good job of going over didactics and surgical skills with them that'll help them treat their patients well for a very long time. My father he had a very poor dentition, and he also had very poor bone. As long as myself, we are from Ukraine, and Ukraine is not famous in the world news right now for their dentistry. Years and years of just poor dentistry, overtreatment, undertreatment led to a pretty poor prognosis for his leftover dentition. He had really pneumatized sinuses that pretty much reached his anterior teeth, so he needed remote anchorage surgery, which I elected to do for him. That's not why this case was necessarily difficult. The difficult part about it is that first incision you do on a parent. That's not really something like any textbook can really prepare you for, because so much pressure, not just in delivering a good product, a good smile, but also surgically, you're in essence temporarily hurting a person to fix their life and fix their dentition, function, aesthetics in the future. Not to mention, right now, I can comfortably go over all these treatment plan modalities with patients because I was there for the surgery for my father, and he stayed with me for the whole week afterwards. So I see day 1, day 2, day 3, day 4, day 5. I know exactly the healing phases of, what my own family member has gone through. So it did help me, but also it was super hard. Like, I was kind of sweating out my Crocs the whole day. 3D printing, digital dentistry, the process is a little different from whatever treatment modality you're doing, but in general, I guess it all starts with the scan. If you want to get into digital dentistry, my recommendation is just get a scanner. start scanning your patient's teeth, their gums, and you'll be able to see things in 3 dimension. You may see some occlusal things you've never seen before. The next step would be get a printer and start printing arches out. You may even print them out at a different occlusion than you're used to. Then combining all those things with a cone beam, a CBCT, now you have a patient scan, and now you have a 3D representation of what their heart tissue looks like, and you can line things up together. I call it in, session 2 lectures, it's almost like digitizing the patient. The more parts of the patient, like an onion slice, I can see on my computer and hide and make translucent, plan certain things here and there, the better. And the better treatment you can achieve for the patient via prosthetically driven planning. The best way that digital dentistry has enhanced implant dentistry, not even speaking about surgical guides, which make your implant deliveries and placements amazing and very predictable, but digital dentistry allows you to see your final goal on your computer instead of eyeballing it in the mouth. We practice a lot of freehand surgery, but we still are digitally kind of guiding it. We place the implant on the computer and we know the case backwards and forwards. We know it like the back of our hand before we start, so that when the flap is elevated, when we see the bone in real life, we know what's underneath. We know where the prosthetic is going to go. If it's a single unit, we want to predict where that screw channel axis is going to exit. We want to predict the biologic with peri-implant tissues, how healthy they'll be around the implant. We account for depth, angulation, mesiodistal spacing, not to mention full arch. That's even more important. You have a set of implants that are all connected together, 4, 6, 8, whatever, but you got to make sure that this prosthetic that the patient's going to be wearing for their whole life, nice and slender, it's not going to get in the way of speech, and it's going to look aesthetic. We always start with the basics of, file types, what types of data you can acquire on the patient, how to digitize the patient, and it's very important to know how to look at the data. So we dedicate a whole few hours of even fast track to evaluating cone beam scans, going through slices, knowing what to look for, knowing how to orient the patient in 3 dimension. Then the next level up would be to combine it with other different sets of data, like dragging in an intraoral scan. The next modality would be putting in a digital wax up. We have training for that too. We can do like 3D digital smile design, either using the patient's, high definition 2-dimensional picture or a facial scan. And then we can do both the planning of the implants, the planning of their final prosthetic, and how it's going to look in their face. Originally, when I started with digital dentistry, they were like, digital dentistry is the future, but I don't think that's the scenario anymore. It's already here. So if you're not doing digital dentistry, you are behind. In the future, the more years that go by, the more handicapped you will be without using the digital tools we have at our disposal. And we're here to teach you guys how to use them and collaborate on projects, and it's just a better treatment for all our patients. A really popular topic from my course is, obviously how to design and how to work with surgical guides. It doesn't mean that every alumni is going to go and do guided surgery. It is the best way to learn how to 3D plan your cases, even if you don't end up using guides at all in the future. But that is a very popular topic. I also teach a lot about kind of anterior aesthetics, how to make a tooth look like a tooth, especially if it's connected to a screw, which sometimes isn't the most straightforward thing ever. And we kind of combine all those things together: digital dentistry, analog or guided surgery, and aesthetics of the restoration they give for the patient. If you're out there for CE, we got you covered. Even before coming in for live patient surgery, the online modules of CE, that's enough to renew your license already. But what's irreplaceable for the CE you get here is getting to work on live patients. I would say it's even a benefit of working on live patients in America, in our facility, just like you would in your own office. These patients come from all walks of life. You know for a fact that whatever implant you place here is going to get restored. And if it doesn't, there's somebody here to handle the complications. Whatever happens to the patient, they'll get something there that's going to please them. Find the CE courses that are going to make you better at the procedures that you want to do. If you want to do endo all day, then take a bunch of endo CE. But if you want to place implants, you can't just take one weekend course and then just call it a day. Of course, you can start placing. After Fast Track, I would say 99% of our attendees, they go home and they start placing implants. There's always steps above that. I never recommend just to stop at one course. I guess our circle of life here at Pathway is, you take Fast Track, you come back, you learn how to do sinus lifts, then you come back, you learn how to do some full arch implant surgery. We basically tailor the courses to what you want to learn and what you want to get out of it. Fast Track is really good about giving you the didactics and also finalizing the didactics with a broad mentor base, one-on-one coaching you throughout your first implant surgeries. That is the best way to handle it, because some courses you go in, you have minimal didactics and you jump right through, some overseas courses. You'll place 40, 60 implants, but it's not about the amount of implants you place, it's how much you learn per implant. Here, you're going to learn a whole lot per implant because you're going to make sure that incision design, the restorative position of the implant, they're all going to be within restorative parameters. The mentor is going to walk you through why. Sometimes more does not mean better. And here, of course, you're going to get a lot of placements, but you're for sure going to learn a lot through those placements. A lot of clinicians are hesitant on doing guided bone regeneration, sinus lifts, sinus bumps. Those procedures can be a lot more predictable if you get the proper training and the proper systems on how to do them. There's ways, even for GPs to predictably regrow bone in certain areas where once they weren't a candidate for an implant, the patients weren't. And especially sinus lifts, when we teach incoming attendees sinus lifts, you are ready to go back next week in your office and you will do lateral windows very predictably and very safely. 3D imaging is irreplaceable when doing implants. A CBCT is 1000% necessary if you're placing implants. It doesn't matter where in the arch, because certain things on panoramic x-rays, on PAs, you will never be able to see or measure. It's a 2D representation of a three-dimensional object, and we want to see things in 3 dimensions. There's lingual undercuts, there's nerves, there's arteries, there's sinuses, there's densities of lamina dura, there's pathologies sometimes in the bone that you can't visualize via 2-dimensional imaging. And you want to make sure that wherever you're planning the implant, or if you can't even plan an implant in the area because the patient has something they need to treat before starting. I even recommend for attendees to get a CBCT that has a pretty wide field of view. Even if right now you don't think you're going to get into sinus bumps, sinus lifts, you still want to see all the way up here in the sinus just to make sure it's nice and clear. And guess what? If the sinus isn't clear, let's see why, and let's see if whether we can give our ENTs, some more information as to why we're sending the patient there. We want to see the ostium, we want to see the membrane, we want to see whether there's mucosal thickening. Not to mention, we want to see both jaws. If we're doing true digital dentistry in order to align their intraoral scans with their CBCT, it is helpful if we see a whole row of teeth on the upper and lower. Immediate load, we can either be talking about single unit implants or bridges or traditional full arch fixed, FP1s, FP2s, FP3s. We teach all those modalities, and it depends on the area we're working on, but even if we're just thinking of it as a broad term, immediate load still requires very, very close prosthetically driven planning. Without that, immediate load isn't going to save your tissue. It may make your patient happy, but we want to make sure they're happy for the long term. So we want to make sure that whatever temporary we give them, whether it's one tooth in the front, whether it's an arch of teeth, it'll mimic what they lost. It'll mimic the tooth that they had before. Right now, a lot of these treatment options during session 2, they are mostly what general practitioners refer out to other practices. It's not wrong to refer out, but there are things you can safely keep after taking something like session two or taking one of the live surgery courses. There's plenty of patients out there for everyone. There's cases that you're not comfortable with right now, but after taking the adequate CE, after getting the training and the mentorship, you'll feel way more comfortable taking on in the future. I find that mentorship to attendee ratio of about 1 to 2 is pretty ideal because lecture-based CE, it's actually honestly for me, I get sleepy sometimes when I'm in a big lecture. A lot of my classmates would know that. But on a 1 to 2 mentorship basis, you're working with a partner, with a mentor that's teaching you didactics, teaching you how to hold the drill, teaching you angulation, way more engaging. And you're going to learn way more from it. It's way more worth your time. Session two in Chicago is happening soon. Come register now. Let's come hang out. We'll do some implants and we'll do some really cool cases together in the future.